So morning everybody, I'm Nicola Stobbs. I'm a consultant surgeon over in Sheffield. I have a particular interest in salivary gland cancer, but I'm a head and neck surgeon. And I'm just going to have a little chat through about thoughts about problems with surveillance and management and what we're trying to do about it. Can we do that? I can do it. So aim 5 is support the development of standardised guidelines for the management and surveillance of individual salivary gland cancers. So this is problem number 1, individual salivary gland cancers. There are 23 different salivary gland cancers that are malignant. They all behave in quite different ways. Management can be different. Then you have all the different subsites of where it can affect. And I'm a head and neck surgeon, but it can affect outside the head and neck region as well. So that is kind of issue number 1. And then issue number 2 is the actual guidelines. So if I go from left to right, these are the UK guidelines that we use, but individual MDTs, and an MDT is a multidisciplinary team, will have their own local guidelines. Normally based on the UK ones, but there will be differences depending on the experts that are available at that particular site and what has been deemed to be appropriate treatment-wise. The other 2 are the European and the American guidelines, and they're quite different, but we're in the UK, so it's the UK ones that we currently use. So this is an MRI scan. Many of you will have had one of these scans. This is a young patient who had a mucoepidermoid cancer, who's very happy for images to be shared. But I thought I could focus in on scans because it is a bit of a contentious topic, and when I arrived I actually heard some of you talking about scans amongst yourselves. So this is a pre-treatment scan. But we're talking about sort of management and surveillance. So what is the actual guidance in the UK for post-treatment surveillance? So I've highlighted some words here because it's all a bit woolly, and that is why you will have all have had different experiences. So patients should be followed up for at least 5 years in keeping with MDT protocols. So as head and neck surgeons, we tend to deal with squamous cell carcinomas. It's a totally different type of cancer, and it can affect all different parts inside your throat, etc. And at 5 years you're deemed as cured. But we know that for some salivary gland cancers, it's a very different story. But you're being managed by the teams that manage the other types of cancers, so yeah, should be followed up for at least 5 years. It says in salivary gland cancers with adverse features, survival curves tend to begin to plateau towards 10 years rather than 5 years, and follow-up should be considered, but it's always should. There's no definites here. Ultrasound may be a useful supplement to clinical follow-up, and then baseline CTs, MRIs or PET CT imaging at 3 months may be useful, and there's no consensus regarding chest imaging as part of follow-up for cancers that have risks of distant mets, such as ACC, which some of you will be living with. So this is why when you are going to your clinicians to say I want to have a scan, that there's no kind of consensus about it. So as a clinician, there are factors that I have to consider when I'm dealing with my patients. So the variety in subtypes and the need for imaging. So some cancers, salivary duct adenocarcinoma is one, which can be particularly aggressive and often can have spread elsewhere outside of the body, versus what we call a low-grade tumour, which is less likely to spread. They've had very good results with surgery and radiotherapy. There's quite a big variety in patients and the risks associated with disease coming back. So I have to consider which patients should I be scanning, which ones shouldn't I. For a lot of you, scans provide some reassurance or early detection to be able to consider other treatments. But for a lot of my patients, and I deal with children who have salivary gland cancers as well, scans can cause a lot of anxiety. There's this thing called scanxiety. Some of you may have it, particularly with MRI scans. They are not pleasant. I've only ever had one for my knee. I haven't actually had to go in the circle of doom, but from a head and neck point of view, they're not nice, they're not pleasant, and they can cause a lot of distress. This might be one that you can help us with. Capacity NHS waiting times to get, when you're being diagnosed, even on an urgent suspicion of cancer pathway, there are delays, there are waits. We can't get things done as quickly as we would like to. If we were to start doing, regular scans on all of our patients, we wouldn't be able to diagnose anybody because the scanners would just be full and there's only a finite amount of resources available. And the NHS is currently pushing for this thing called PIFU. I don't know if any of you have heard of this, patient-initiated follow-up. So it's not really a thing for salivary gland cancers, but in our other subtype of cancers with the SGC, there's research going on at the moment where patients will have a scan after they've completed their treatment and then another one 12 months later. And if there's no sign of any disease, at that point they get discharged with an open appointment after having some patient education. And the NHS is really trying to push this because it's, we just can't fit in the patients that we need to. So that's kind of what we're up against as clinicians. It's a balance of making sure that you are all being treated as well as you should be versus actually what we've got available to us. Different healthcare systems. So the European and the American guidelines are very different, but they are very different healthcare systems, and you pay for your scans and it generates income. My friend lives in America. She has a benign thyroid nodule. In the UK, you have a benign thyroid nodule, you get discharged. She goes for 6 monthly ultrasound scans lifelong because she pays her surgeon for that. So some of the guideline differences are to do with the different healthcare systems. And then there is the radiation risk. So not with an MRI scan, but if you're having regular CT scans and PET scans, there is a small increased risk of you developing other cancers because of the radiation. So back to the aim. Support the development of standardised guidelines for the management and surveillance of individual salivary gland cancers. You can see it's really tricky. And so the work that we are doing as part of the research group is actually finding out what is being done at the moment, because there's such a variety of practice around the country, and then that will help feed into us to be able to then develop what we think should be happening.